Hello, my name is Dr. Azam, and I'm a student at the Diploma in Sports and Exercise Medicine at University of South Wales. Today I'm going to show you the examination of the hip joint. With me is Umar, who is a field hockey player, and he has volunteered himself for this task. I thank him. Alright, before I move on to the examination of the hip, I would require a detailed history regarding the complaint of the patient as well. And before I start the examination, I would require a proper exposure of the patient. Ideally, he should be wearing his underwears, and so that I could easily inspect around the hip joint. But for the sake of dignity, he's wearing his shorts as well as the shirt. I'll have a look at the general appearance of the lower limb. The alignment is very well, but there is no deformity at the knee, ginovalgum or ginovarus. I don't see any pes planus or pes varus. Can you turn around from me? And there is no overpronation of the subtalar joint. Right. Now I'll inspect the patient hip joint for any deformity, skin discoloration, any surgical scar mark from previous surgery, or any scar mark from any injury. I'll also have a look at the muscle wasting, if any. I don't find any. Alright. Thank you very much. Next, I move on to have a general look at the gait of the patient. Can you walk down a few steps for me, back and forth, from the side and from the back, and keep moving. While walking, I will have a look at the cadence, the stride length, which part of the foot strikes first, any indulgent gait, or any leg preference from one over the other. Right. After I've observed the gait of the patient, I will also have a look at the shoes of the patient, see any particular pattern of the wear and tear, any inserts. No, I don't find any. Right, thank you. Next, I will perform the palpation. In the hip, there are 4 points which are very important for the palpation: the anterior superior iliac spine, the greater trochanter, the pubic symphysis, and the ischial tuberosities. These 4 points should be palpated for any pain, and also the Jerry's tubercle for. Alright, thank you very much. Next, I will be performing the Trendelenburg test to assess any weakness in the hip abductors while standing. Can you turn around for me, please? There are several ways to perform the Trendelenburg test. This is the one I prefer. I'll be checking, for the sake of demonstration, I'll be checking his right hip. Can you stand on the right leg and kick your left leg behind, please? Have a look if there is any drop down of the pelvis on the side which is not being tested. If there is any drop down, sagging of the pelvis on the left hand side, it shows that there is a weakness of the abductors on the right hand side. Thank you very much. He's perfectly fine. I also ask him to take a deep squat take a deep squat to have a generalized idea of the strength of his muscles. Thank you. Can you sit down for me, please? Right. While sitting down, I always prefer doing the strength of the iliopsoas muscles, and which pretty much easier for me to do this. Can you push against my hand? And push against my hand. You can also check the range of motion and external rotation, internal rotation, as well as the external rotation as well as external rotation. Right, thank you very much. Can you lie down for me, please? Right. While lying supine, we will be performing the range of motion exercise, range of motion passively, actively, as well as we will be checking his muscles against the resistance. Right. Flexion, can you bring your knee towards your chest and check it passively. Check it passively. Right. Can you check the adductors of the external rotators, internal rotators, the external rotators, range or angle of both of these movements are perfectly normal. Right. Adductors, and can you slip yourself on the side of the couch? Right, thank you. Adductor. These are perfectly normal. Can you lie on your side, please? While lying on the side, you can also, it is very easy to check the strength of the hip abductors against as well as the adductors against the resistance. Can you push against my hand? Push against my hand. And relax, please. And downwards, can you push against my hand? Check the adductors as well. Thank you very much. Can you lie down on your tummy, please? On your tummy. Full turret. Right. And bring the leg straight up. Check the extension. Passive range motion and extension is perfectly normal, about 20 degrees. And check the passive range as well. Actively check the extension range of motion for the hip, and then passively against the, it is perfectly normal. Also, can palpate the ischial tuberosities for any hamstring tendinopathies. Thank you very much. See that later. Now I'll proceed on to the special test. First test which I would like to do is the straight leg raising against the resistance, which give me a general idea if there is any pathology, if there is a pain in the hip. I can modify my rest of the test. Again, can you bring your leg up at about 30 degrees? You can put against resistance against while doing the SLR. And if there is any intra-articular pathology around the hip, patient will feel the pain. Right, thank you. And do it here again. About 30 degrees SLR. Thank you very much. It's perfectly normal. Now move on to the FAIR test. FAIR test stands for flexion, adduction, and internal rotation. And it's a very good is a very good test, although very non-specific, but very good test to assess any intra-articular pathology, to assess the femoral-acetabular impingement, to assess the labral tears, to assess the psoas bursitis, as well as the piriformis syndrome. Right. We should do the FAIR test. We should bring the hip to the 90-degree line and bring it to the adduction, and internal rotation. And if the patient feels any pain around here, it signifies the pathology around the hip. Okay. There are also modified version of the FLAIR test, which is quadrant test, and you can encapsulate the hip, the knee joint, and bring the knee to the different angles to reproduce the pains. Right, thank you very much. Next test is to assess the intra-articular hip pathology as well as the SIJ joint. This test is known as Petrick test or the Faber test as well, also known as the Fair-4 test. Faber stands for flexion, abduction, and external rotation. And if there is any pain on a slight pressure or without pressure in the inguinal area or front of the hip, is more likely the pain is coming from the pathology around the hip joint. And if it is reproduced with more pressure and in the buttocks area unilaterally, there is high likely chances it is coming from the lumbar region or SIJ joint, from the SI joint. Alright, thank you very much. Next test is Thomas test, which we do to assess the any shortening of the iliopsoas muscles, the hip flexors. I do in the sports medicine, we prefer doing it than doing the modified Thomas test. Can you come down on the edge of the couch, please, and stand up? Our assessing is left side of the hip. In order to do it, I'll ask him to grab his right knee and lie down with it and hug the knee to the chest. I will look at the left thigh. If it is significantly lifted up from the couch, shows that there is a shortening of the iliopsoas muscles. Also, we can see that if there is an abduction instead of the flexion, as it is evident in the case of Umar, is high likely chances that his iliotibial band is tight, which we will confirm on the Albert's test. Thank you very much. His iliopsoas muscles are perfectly normal. Now we move on. As we have seen that Umar's iliotibial band is suspectedly tight on modified Thomas test. We will perform the Albert's test to confirm it. And can you turn around for me to this side, please? And to do this, bend the knee which is not being tested and ask the patient to hug it to the chest to prevent the rotation of the hip as well as the lumbar spine. And I'll put my elbow on the pelvis to prevent the lumbar spine and bring the hip into extension and abduction. And if there is any tightness in the iliotibial band, the knee will not fall on the couch. Normally it should fall on the couch. In case of Umar, it does not fall on the ground. So it shows that his iliotibial band is tight. Thank you very much. And lie down straight for me, please. Next, final test we'll be performing is the length of the limb to assess any discrepancy of the limb length. To do this, I can take a tape measure, and from anterior sphenoid spine to the medial malleus and to this side, and compare see the difference between two sides. Normally, it is more than 1.5 centimeter is significant and should be corrected. Another way to check the length of the limb is to put the patient's limb into 90 degree, and from the sideways have a look at it. If one knee is higher than the other, it is high likely that the limb discrepancy, the length of the limb discrepancy is due to the tibial length. But if you look from the head end of the patient, and the one knee jets out from when you compare it to the other, is likely that the femur is responsible for the leg length discrepancy. Thank you very much. I will conclude my examination of the hip with the complete neurovascular examination of the lower limb, with examination of the knee, as well as with examination of the lumbar spine. Thank you very much. Andy.